Guys able to see the are you able to see the screen? Make sure we got the right screen up here. It's all good?
Yes.
Okay,
Yeah.
awesome. So, and I'll borrow from Dan's comment about his work with your patients, that you may have patients with this. This is a concept that I find very interesting, but it's very vast and complex, and time's not going to be adequate to really cover this as well as I'd like to. So I'm going to go through it, and I encourage you to check out some of the references and things that I'll have at the back to kind of dig into it a bit deeper. So let me begin. So what I'm gonna try to do is talk a little bit about how relevant religious and spiritual coping is in psychosis, a little bit about a framework for thinking about it as a clinician, offer a couple of tools, and not go into a lot of details, for assessing religious and spiritual coping, and then some strategies that are informed by CBT, and think about how to work within this this area from a CBTp perspective. All right, so one of the first questions I thought about is, religion and spirituality important to someone who experiences psychosis? How important is it? Next little slide comes up. So looking at the literature, at a conservative estimate is over 60% of those receiving treatment for serious mental illness indicate religion and spirituality is important and helpful in their life in some fashion. I'm not going to go into detail on the next slide, but the table provides a selection of studies, inpatient and outpatient, and how many individuals in each of those settings found religion and spirituality important, and some very important in terms of helping them to cope with, make sense of their psychotic experience or what they were going through. Sometimes it helped with support, sometimes insight, other kinds of things along those lines. So for a percentage of the folks we work with, reliance on religion and spirituality is going to be important. So then the next question that comes up, one of the next questions we might think about is, well, how do we address spirituality within the context of mental illness? And, it's a tricky area, because there's a variety of belief systems. It's a belief system that's very vast, and parts of many of those belief systems are not scientifically provable, right? So, and as mental health providers, most of us trained in, universities, we have a more science perspective and empiricism perspective. And so what I want us just to think about for a second is that continuum, or just categories of science and medicalization of experience, and then religious and spiritual belief systems. And I'll mention that Ron Unger does a nice course on this. Part of preparing for this, I did his webinar on this, and it's several hours. There's a lot of stuff in there. So I try to insert little pieces that I thought were helpful. And one of the things that came up from this thinking about framework is that when we see individuals who begin to talk about spiritual experiences, God, devils, things like that, because they're trying to make sense of whatever experience they're having, there are at least those two big ways to kind of think about it. And Unger encourages us not to be careful to not fall into rigid categories. So not separating out the religious part and just saying, oh, it's not the illness, it's just part of my spiritual experience, which the result could be avoiding treatment, rely on a faith practice only. But then conversely, to not just dismiss and say, oh, they're talking about spirituality, it's demons and devils, it's just psychosis. There's no spirituality, so avoid and don't talk about religion, because that's going to kind of add to the, to the problem in the particular situation, right? And so kind of thinking about for yourself where you fall on that continuum based on your own experience and comfort with those things. And Unger, of course, and CBT would say, try to be holistic, and really a lot of what we do is try to understand experience in different ways. And the fact that, psychosis and having a spiritual crisis may not be all bad, there may be benefits, and then costs and risks, of course, with having an experience like that. So that gets to my next point, thinking about change process. And it's kind of interesting. Early on, thought about psychosis from a medical empirical standpoint as, a biological event causing distress and disruption, and we treated it strictly as an illness. Now, a more common way of thinking about it, we've all been schooled in recovery views that a lot of things can lead to psychosis. Biology is one, but trauma could be one aspect, and a very common aspect. And sometimes psychosis reflects an effort to deal with that trauma. Now, if we go back a couple hundred years, when individuals would have a crisis, breakdown, things would change, often they would be described as a spiritual crisis. And they would explain it in those terms, and that was the language they had at that particular time. But there were some elements that were similar, that, there was something that was difficult, but there was an understanding that sometimes it preceded important change. All right. And so there was kind of the current state was flawed in some fashion. And so there was a breakdown in constructs and then the constructs were restructured. Richard Rohr talks about the wisdom pattern that goes from order to disorder to reorder, which reminded me a little bit of Adrian's comment about like his 3 different steps. There is a wisdom pattern in some change that happens like that. And so when we think about a psychotic experience or spiritual crises, there are some similar elements. I'm not saying they're exactly the same, but we can think about them in similar ways. And Unger says that what determines the outcome of an experience, so I hear a voice or I have a spiritual experience, whether it's harmful or leads to growth, often depends on the context, where it happens, how the person appraises it, how do they make sense of it, and how others respond to them. So if I hear voices and someone says you're crazy, go to the hospital, or someone says, geez, I wonder what that's about. Maybe there's something important here to look at from your faith tradition, has a very different feel about how a person responds to it. All right. And then the third piece that's important in terms of perhaps growth and transformation is the ability to integrate it into one's life. So the normalization message, when there could be spiritual themes within psychosis, is that it's, first of all, it's not uncommon to experience crisis in different kinds of ways. And sometimes it includes unusual events. And sometimes that is necessary on the way to change, to get to a place of thriving and flourishing. Sometimes there needs to be a real kind of fundamental reorganization of things. And so in thinking about that perspective, I found a couple of examples, respected figures that were at this intersection of kind of spiritual experience and psychosis. So the first is Anton Boysen, and this individual was brought to my attention by Fred Fries, who was a big advocate and person with lived experience. And Anton Boysen was had sort of a diverse background, but ended up becoming a pastor working in religious circles. But he also had a real calling to work within hospitals. And this is sort of turn of the century in the early 1920s. And he developed a method called clinical pastoral education. And the idea here was to kind of help pastors move from just their congregation, churches, wherever they were at, to actually meet people where the suffering existed. So in hospitals and places like that. And you could learn about a person's spiritual experience from a scripture, a sacred text, and you could learn from the person themselves struggling. And Anton Boysen was someone who experienced psychosis, schizophrenia, a number of times. And through that experience helped him to have a clearer understanding of this concept. And he was really motivated to bring science and religion closer together. And he was also reported that certain mental disorders and religious experiences are alike in their attempts to reorganize their life in some fashion. And so here's an individual with psychosis, and from that developed a way of training pastors, and many pastors who work in hospitals have this sort of methodology where they go in and get this kind of training based on his experience. Another person you've probably heard of, Marsha Linehan, who developed dialectical behavior therapy. Many years after her approach was very successful, she wrote a book, Building a Life Worth Living, and did several interviews where she talked about her own experience in the 1960s, where she was hospitalized with all kinds of self-injurious behavior. Some reports, and I don't know the exact diagnoses, but could have been psychosis, could have been involved. I don't know the details of it, but she was in some dark places during those times in the 60s. She was also from kind of a Christian background and was in a temple, or not a temple, in a chapel praying one evening. And then you'll see the description of her experience. She was kneeling there, and essentially everything sort of changed. The place became gold. She had some colorful images, a shimmering experience. And then she had a very experiential sense that she could really love herself and really felt transformed in that moment. She went back and reflected upon it. And from that experience, she had this, and she describes it as a religious experience. She came up with this idea of radical acceptance and the need to change. So the idea of embracing opposites, that one can both love and accept oneself and feel the necessity of change at the same time, kind of came from this spiritual experience from her struggles. So interesting normalization stuff. So from a CBT standpoint, so how do we approach this? Well, with CBT, we always start with some sort of formulation, trying to make sense. So we always start, obviously, with developing the relationship. But once we develop the relationship, the fundamental task is to kind of help the person make sense of their own experience. And so this is where we put a lot of emphasis on listening to their perspective and working within their belief system. So we're not trying to impose anything, but really that curious, like, help me understand, try to get a sense of what they are experiencing, how they make sense of it. And to be in that space, Ron Unger and others talk about, we have to manage our own uncertainty and our own biases, from our own backgrounds and beliefs about things, and to really strive for a dialogue that allows for a safe space where the person can feel safe enough to talk about their experience and to consider maybe alternative perspectives. Just a couple of notes on tools. There are a couple you could look to. There's one called the Brief Recope, and it's a 14-item measure of religious coping that Pergament and colleagues came up with. And it's based on the idea that religion and spirituality can be helpful, but there can also be maladaptive elements. And the items ask about things like meaning, control, comfort, intimacy, and transformation to try to get at what's positive religious coping and what's negative religious coping. And so you can see some of the items demonstrated there. Royston modified it slightly to put the word higher power with God and make it more culturally accessible. And rather than saying church, put religious community to also, again, make it a little bit more culturally diverse. Sylvia Moore has done a lot of work in this area as well and has a semi-structured interview. What I like about this interview, and I can send this afterwards for those interested, is it asks just generally, very open-endedly, what's helpful and is religious and spirituality helpful? If it is, then you go further in the interview. If it's not, then you go a little bit of a different direction. So it kind of gives you room to do that. And then the third tool, and I'm not going to spend a lot of time, this comes from Weissman, Dememe, and colleagues, the culturally integrated treatment for schizophrenia, has a handout for individuals who don't identify with a very specific religion, but they have some questions they can ask about, like what values are important, what beliefs guide you, what are your concepts of morality, right and wrong. So it kind of gets at some of the kind of higher order kinds of things without necessarily encapsulating it in a particular religious perspective. So a tool worth looking at. Now, one of the things I found helpful in looking through the stuff that Moore and Pergament did was to kind of identify behaviors and actions that seem to be correlated with recovery and doing a little bit better, and stuff that tends to be less helpful as we're trying to guide folks that we work with. So the helpful spiritual religious practices, if we, and again, apologies to put them into categories. The helpful ones were when there was a sense of spiritual support and collaborative religious coping. And so that's really sort of like the person's not in it alone, their higher power or God helps them. Congregational support. So if an individual has support from the religious community that provides both practical support, sometimes it's transportation and help otherwise, and just a place to be and be accepted, super helpful. And then the idea of benevolent religious reframing, and I'll talk about what that means, but casting even difficult things in a more benevolent light. The unhelpful things were when the individual reports strong themes of discontent with God and congregation, really abandonment themes and punishment themes. So the negative reframing as the experience is punishment for sin or whatever, and emphasis and focus on that tends to correlate with less effective recovery. There's mixed results on the actual religious practices and rituals, and some of that depends on context, longitudinal studies, how long a person does it. But an example of practices where it gets in the way is if a person becomes absorbed with their practices, and there's a couple cases I'm thinking of where the individual spent so much time in a particular religious practice, they weren't eating, they weren't having relationships, things like that. And so when a person gets absorbed, that's usually a pretty good indicator that's not being particularly helpful. All right, so once we have a little bit of a sense of what's going on, we have a sense of like, here are the kind of things that tend in general to be helpful for folks. What kind of things can we do as CBT therapists in these situations? And a lot of it is basic CBT approaches and then helping people enhance positive religious coping where possible. Let me just talk about that briefly. So in CBT, we work a lot with thoughts. And again, as I said, and I can't overstate it, respect for the importance of the belief. We have to have humility about this, whatever their experience is, but also being open to whatever they're experiencing may have a transformative aspect as well. And maybe something in there that is really the person's effort to try to get the healing, but there's a lot of stuff in the way. We use strategies to help people differentiate information. The voice said, I should do this. And the interpretation, well, the voice must be God and must mean this. Well, when we get to the interpretation level, once we have that relationship, we can work with that a little bit, and that goes to my next point. Like, let's say for a moment the voice wasn't from God, but an imposter. Would that make it a difference in the way that you feel? That's a question right from Chadwick and his work with, religious and spiritual kind of themes. And it's really just a way to tilt a little bit. The voice never claimed to be God, and you wonder about it. What if it wasn't? What would that mean? So you put them into a different alternative perspective, another way to kind of think about it. Or you might ask a question like, well, why were you selected to hear this? There might be something about importance and value and people respecting them. And that might tie to other psychological themes or developmental themes that have gone unaddressed, or maybe there's a deep wound there. And Unger talks about something called a spiritual bypass. And what he describes by that is sometimes the appearance of the divine or the spiritual is a bit of a cover for deep wounds, vulnerability, or developmental tasks that weren't accomplished that are very difficult to face on directly. And so it gets a bit absorbed in this other space. And part of his argument is that sometimes people need to feel, when it's in a benevolent way, that support and security to be able to then face whatever it is that they, whatever the trauma was or whatever the developmental task that went unaccomplished was. So, and again, that's that idea that it's not all bad or all good, but kind of looking at how this fits in the larger picture. And I just sketched out a progression that could happen in CBT where, I'm hearing a voice telling me that I'm evil. On the one hand, what's the appraisal? The person might say God, or the devil, and then what does that mean? Or we could talk about an appraisal that it comes from an illness. We can do some normalizing. It comes from the mind playing tricks or stress or sleep deprivation, which then has other outcomes. Or we could have an appraisal that this could be informative or guiding, and there could be underneath that some themes that could be addressed in a more traditional psychological way. So just a way to kind of think about alternative perspectives. One of the things, and I'm going over time, I'm going to talk about just a couple more things. One of the helpful forms of religious coping is benevolent reframing. And so that for any of us, when negative events happen, it's easier to bear when understood from a standpoint of love and care, that there's something or someone who loves and cares about us in the midst of our suffering. And that may be individuals, families, loved ones. And for those who have a religious or spiritual system, often there can be an appeal to God as being present there as part of that help. And so when it's there, it's particularly helpful. When it's not there, that's where some of the difficulty comes in. And often what this ties into is compassion. And compassion is a central tenet of most of the common faith traditions. And it's more recently been incorporated into a mental health treatment approach, compassion-focused therapy. And so some of the work that we do may be helping individuals move towards compassion, whether it's from their own faith system or whether it's within something that we call compassion-focused therapy. We can appeal to it. So an example from one of my own individuals I worked with, the devil was always tormenting him when he made mistakes, when he would misplace things. And the sub-belief was God does not love me, is punishing me, has abandoned me. All right. So that's the negative religious framing, right? And abandonment, all those negative things. So in the CBT approach, we spent a lot of time just looking at when mistakes occurred in a typical CBT, like asking curious questions, trying to figure out what's going on. And we discovered that mistakes happen more often when he was rushed or stressed or other kinds of things. So we worked on de-stressing, taking his time, being a bit more patient with himself, and that seemed to help. And then we also looked at the sub-belief about being punished and abandoned. And he was a fairly faithful person from his own Christian tradition. His sibling was a pastor, in fact. And so we looked at themes from his, from his faith tradition, and really he realized that goodness always overfavored punishment and mercy and forgiveness. And so we just focused on that. And so we strengthened this view daily with some reading that he would do with his sibling that was involved in this. And he even got to the point where as he was getting better, he wanted to write, we would call it a recovery story, but he would call it a witness. Like I was able to do better because of people and because of God, and was like that kind of thing. And so he went from a real negative framing to a more positive framing, and tied in compassion quite a bit with that. The other forms are just the sense that we've already talked about perception support. Let me just say a quick sentence about collaborative coping. And this is the idea that the person shares the burden, if you will. And it's kind of the idea that it's sort of a surrender in a sense, but not a surrender like I can't do anything and passive avoidance. It's more of like, I'm going to give what I can't control to God, higher power, whatever, and I will do the part that I can, but I'm not in this alone. So this collaborative coping sort of process can be helpful. And it's been correlated with better outcomes in terms of quality of life, et cetera, et cetera. With regard to faith communities, repeated studies show that individuals often turn to clergy first before mental health professionals. And when it's available, it's a hugely positive form of support. The downside is smaller percentage do not engage with faith communities. And often it's either due to symptomatic behavior, which then they get kind of ostracized, or just rejection from their faith community for whatever reasons. And that can be particularly painful for individuals. And so what you can do to go from isolation to community is if, reaching out to the person's faith tradition in some fashion, maybe there's a pastor or clergy, somebody who they can speak with, that would be helpful. Be helpful to contact that person ahead of time, get a sense of their mental health, spiritual continuum, but certainly be open to those possibilities. And then from the CBT family end of things, family can often be a great source of benefit to kind of help look at some of these faith-informed things. Could also be a point of stress, especially when there's conflicting values within a way to interpret one's faith, which may be even more important that you bring in the family in or at least work with them in some fashion. And this I will, refer you back to the culturally informed treatment for schizophrenia by Waisman and Domain mandate. Their treatment approach is both very family focused and collective, and it has a big piece for faith and religion as well. So something to think about. And for the final recap, certainly be open, aware, and holistic. I'll add humility to that. Follow the general CBT principles, mainly collaboration and really kind of learning from them. And then as you identify things to work on, the directions to head are benevolent reframing, collaborative coping, compassion, all those kinds of directions, and then optimize family and congregation support when possible. For those who are really jazzed about this kind of thing, there is a whole CBT approach that has been developed for 5 faith traditions: Buddhist, Hindu, Muslim, Jewish, and Christian. So they take the teachings of those faith traditions and connect it directly with CBT. If you go to the link, you can get manuals written from each of those perspectives, if that's something that you're particularly interested in. And then you can look at the rest of the references for other places to go, including the Ron Unger training that I talked about. All right.